Hi guys, yet another session of OBGynuggets and I'm back. Today we shall be discussing a case scenario that intrigued me. It intrigued me when I was a resident and I decided to have a discussion on this topic with my current residents a couple of days ago. This was a clinical picture that you could see in the picture over here, and it was a very nice discussion that I had, which I decided that I'd also have with you all today. So the discussion is going to be on whether to give or to not give anti-D to patients who have had molar pregnancy. I shall also be touching down upon first trimester abortions and ectopic pregnancy and whether we should be giving it to them or not. Now there's a disclaimer here that for people who work in civil hospitals like I do, anti-D is a drug that we get over there for free, whereas in private setups it is something that costs around 4,000 to 5,000. So it's an expensive drug that way. Most patients can afford it who go to a private setup, and in our hospital it's not an issue because it is provided for free. But let us assume for the sake of this discussion today that this drug costs like something like 4 lakh. So there's a price on it. There's a price tag on it that is not making it affordable and available to all the patients. Just assume it for this discussion today. So we have to be very judicious on giving it to our patients. So these are the 3 categories of patients that we shall be talking about, that is molar pregnancy, abortions and ectopic pregnancy, and whether we should be giving this expensive drug to all of them. So welcome to the session and here we go. So this clinical picture that you can see was a patient who was a primi gravida at 9 weeks of gestation. She had come to us with an incidental finding on her scan that suggested a complete molar pregnancy. So we did all her basic workup. We did basic workup of her thyroid profile to prevent thyroid storm, precipitation of thyroid storm. We did her chest x-ray. We got her ready for the procedure, and then we did a suction and evacuation. And when we did that, this was a picture of the products that were emptied. Now basic over here, these vesicles, these grape-like vesicles that are very classically seen in complete molar pregnancy are the ones that are because of the edema or hydropic changes of the chorionic villi. वो प्राइमरी सेकेंडरी टर्शरी जो होते हैं उसमें जब इडिमा होता है उसको ये लुक आता है, इट लुक्स इन दिस फॉर्म. दैट इज ऑल्सो व्हाई वी कॉल दिस हाइड्रेटिफॉर्म प्रेगनेंसी और हाइड्रेटिफॉर्म मोल. The other name for this is gestational trophoblastic disease. Why do we call it trophoblastic disease? Because what we are not seeing over here with naked eye, or we are not able to appreciate it in these vesicles, is the presence of hypertrophic or rather hyperplastic. There's a huge proliferation of trophoblasts that occurs in this as well. Hence, we also call this gestational trophoblastic disease. Also remember that we don't call it hydratiform neoplasm. We call it gestational trophoblastic neoplasm for the cancers because there is excessive proliferation of the trophoblasts and not these vesicles in patients who have neoplasm. So we have to remember these 2 definitions and why do we call them by those names. So in this picture, there is presence of both hydratiform changes, the edematous vesicles also, as well as trophoblasts that have had hyperplasia. So this is a picture in which we have both of them, but we can see the vesicles more clearly. So once it was done, this patient was Rh negative patient. She had a blood group that was Rh negative while her husband was someone who had Rh positive. Now on the scan it was given that it was a complete mole. It was confirmed twice by us and radiologists as well. And in a complete mole, as you all know, that there is only the paternal sperm. There is a paternal antigen that comes. So there's a sperm that fertilizes an empty ovum. Either the sperm multiplies into 2 or there is another sperm which also fertilizes. In that kind of scenario, there is just the paternal diploid state that the hydratiform mole has in general. But it contains all the father's genes. It also contains the father's gene of Rh antigen in the first chromosome, but it has not expressed in the form of, it has not converted into a phenotype of an RBC. So RBCs are not being formed over here in patients who have complete mole. Whereas in partial mole, there are fetal parts. The fetal parts also have the maternal antigen. They have the maternal genome. They also have RBCs, and that RBC also has the Rh factor. So without a doubt, for patients who have a partial mole, they are candidates for receiving anti-D. But in patients with complete mole, what's the scenario? So I need to understand that there's a factor over here that I need to be very clear about, that in patients with complete mole, the diagnosis of complete versus partial mole is never based on ultrasound examination. That is just a sign, that is just an indicator, something that tells us that this probably 90% of the times is going to be a complete mole. But you need to remember that a definite diagnosis of complete or partial mole is only given by histopathological examination, immunohistochemistry, and karyotyping of the products. Immunohistochemistry is for P57 antigen, which will help to differentiate between these two. Histopathological examination will help me to differentiate between complete and partial as well. Whereas karyotyping, because the presence of maternal antigen in partial mole will make it triploid, whereas complete mole will have it in diploid form. So 2N or 3N is decided by karyotyping. So IHC is at least a must that needs to be done on these specimens. Now in most of the centers, we only have HPE. We probably do not have IHC. We don't even do karyotyping. It's a very resource intensive thing. So in these patients, we will never know whether in actual the complete mole diagnosis that was given to us was indeed a partial mole that we probably didn't diagnose, or there was just a small part of partial mole that was present in it. There was a small fetal part, but we just couldn't differentiate it. All we saw were these hydropic changes, and we sent them for a histopathological examination. So in that scenario, just purely on the basis of histopathological examination, we will not be able to make out whether it was complete or partial. In that scenario, if the mother was having a partial mole, which we incorrectly said to be a complete mole, and we decided to not give her anti-D, it would lead to a loss. Also, even if I did have histopathological examination, I did have immunohistochemistry, I did have karyotyping, these reports take 2 to 3 days to arrive. Now, 2 to 3 days are enough for isoimmunization or isosensitization to occur, and hence, until that diagnosis is actually established, I will end up wasting a lot of time, and that isosensitization will already have occurred and her next pregnancy is likely to be affected. And hence, in all the patients, be it complete or partial, for both of them, we give the benefit of doubt to complete mole and we do end up giving them anti-D. So both are candidates for anti-D on the basis of this. Now, guidelines, British Society of Hematology guidelines, they say that irrespective of all these things that we have discussed, you have to give them an anti-D. I agree with it, but the reasoning behind this, if you want to go into the intricacies, is going to be this one. The next question that arises then is that there are other conditions or at less than 12 weeks of gestation. Obviously, the dose of anti-D that I'm going to be giving to this patient, by the way, is going to be 50 microgram, or what you can also call as 250 international units. दोनों same ही है, कुछ फर्क नहीं है, because it is less than 12 weeks. Ideally, we have to do the KB test to determine fetal-maternal hemorrhage कितना हुआ है, then we have to give it. But if you don't have those things, you don't have the apparatus to do it, then you can just give them this dose. The next question is for abortions. What about abortions? Now I have multiple types of abortions that are possible. A patient comes to me with a complete abortion. The patient says that I have had bleeding. The bleeding was scanty. I did not even have pain. The patient comes to me with a scan suggestive of complete abortion, which was painless and scanty bleeding. Whereas I can also have a patient who has come to me who is actively bleeding, and the patient is saying I'm also having a bit of pain in my lower abdomen. So it can be either an incomplete or inevitable abortion. I'm not going to do the definitions of these. So painful and काफी ज़्यादा bleeding. Whereas the last possibility would be something that is an induced abortion, or what I'd also want to call it as MTP. You have done a medical abortion or an MTP for that patient by giving Mifi plus Miso. ये दोनों देखे मैंने किया हुआ है. Obviously, when I give the patient Miso and Mifepristone, the patient will have pain as well as a bit of bleeding. Now, why have I focused a lot on these two words, pain and bleeding, pain and bleeding. I need to understand that the pain that is coming through is because of the contractions of the uterus. And whenever there are contractions, there is going to be a risk of feto-maternal hemorrhage. There is going to be isosensitization that occurs. So in a patient who has had a painless and very low amount of blood that has gone in, I need not give them anti-D. For a patient with complete abortion who has come to me, already complete abortion has been done. There was nothing that was required to be done. It was painless. There was also scanty bleeding. I can be assured that there is not going to be any isosensitization. You don't need to give that patient anti-D. On the other hand, if the patient has incomplete or inevitable abortion and the patient has had painful bleeding, the patient can have two outcomes eventually. The two outcomes, I'll do it with the black pen. The two outcomes are going to be either I wait for spontaneous conversion to complete abortion, तो मैं spontaneously complete abortion होने के लिए रुक जाता हूँ, or I do surgical evacuation. I do a check curettage, I do a suction and evacuation, or I do a manual vacuum aspiration. So these are the two outcomes that I can do for that patient. In either of the scenarios, whether I have waited upon for that patient or I have done a surgical evacuation, I need to understand that surgical evacuation is going to lead to feto-maternal hemorrhage as well as complete abortion. Even though it might happen, the patient already had pain and the patient also had lots of bleeding. She is a candidate for receiving anti-D. Similarly, if it was a complete abortion but which was a lot painful despite scanty bleeding, then she will be a candidate for anti-D. Basically, contractions lead to pain and contractions lead to feto-maternal hemorrhage. These are the candidates who should receive anti-D. Finally, induced abortion using an MTP. In most of the cases, it can be either a medical abortion or in few cases, we also do a check curettage. We do a suction evacuation or we do manual vacuum aspiration or we just do a dilatation and curettage for these patients. In either of these patients in whom I've done this, I have given this patient mifepristone and misoprostol. They have had pain. They will have contractions obviously, and hence these are also candidates for receiving anti-D. So for all patients who have had surgical abortion, surgical evacuation, for all the patients who have had pain, who have had excessive bleeding, they are all candidates for receiving anti-D. The only person who is not a candidate are a small percentage of patients who have had painless or scanty bleeding. Fine. The last aspect of my discussion today is ectopic pregnancy. So ectopic pregnancy is a very controversial topic for anti-D. The earlier guidelines said that obviously, by the way, we have two ways of managing it. We can either have medical or expectant management. Medical is basically I give the patient methotrexate. Expectant is where I just wait and watch. I just do a repeat beta HCG monitoring. And the other one is where I do a surgical management wherein I either do salpingectomy or I do salpingostomy. So in either of these patients, obviously for patients who I have done surgical exploration, there is going to be feto-maternal hemorrhage. Probably the patient has already had a ruptured ectopic pregnancy. They will have feto-maternal hemorrhage. They have undoubtedly a high risk of iso-immunization. I'll be giving it to them. For patients with ectopic pregnancy who are being managed medically or by expectant management, earlier there were a few guidelines or there were a few literatures that say that you need not give them anti-D. But the current evidence says that they have seen that patients who have been managed with methotrexate or have been managed expectantly have also had iso-immunization, and hence again I would like to give the patient the benefit of doubt because it might affect her subsequent pregnancy, and I will give her anti-D as well. So in short, I have to give anti-D to all patients with molar pregnancy. I have to give anti-D to all patients with ectopic pregnancy. I have to give anti-D to all patients with abortions except the ones who have had complete abortion without the requirement of surgical evacuation and who did not have pain or excessive bleeding per vagina. Otherwise, inevitable abortion, incomplete abortion, patients who have required surgical evacuation, medical termination of pregnancy, induced abortion, all of them will receive anti-D. If you don't want to remember anything of this, just go ahead and give your patient anti-D. But in your exams, you need to remember these concepts to be able to answer. It will impress your examiner a lot. So that is it for the discussion today on kisko anti-D dena hai, kisko nahi dena hai. These are all the scenarios for patients below 12 weeks. For patients above 12 weeks, we have had separate lectures on them on our application at Conceptual OBG. So thank you, and I'll see you again in the next OBGY Nugget. Bye.